Just wait. I think there's something that is not right here. Hi, there was some bad feedback there. Okay, sure. So can I go live now? Okay. All right. Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi channel via multiple social media platforms, Facebook, YouTube, Twitter, Instagram, and also via the Dr. Fundi channel. Welcome. Today we have an interesting conversation in prospect. We are going to learn, we're going to be inspired, we're going to be motivated. Our special guest today, as you know, on Sundays, we normally have what we call Salute Sundays, where we invite one person to help us to, to understand their journey to the top, as a way of celebrating that person, as a way of also making other people aware that if you commit to doing something, you can achieve it. So our special guest today is Dr. Gugu Kali. We used to call her Gooks when we were at medical school. So Dr. Kali is a senior specialist. Now, she's a senior specialist neonatologist who works at Stellenbosch University and Tygerberg Hospital in Cape Town. She grew up at Butterworth in the former Transkei, that's in the Eastern Cape. She did her undergraduate training at the former University of Natal, Durban. That was in the 80s. And she later trained in pediatrics and neonatology in Cape Town at UCT. She then spent some time working in academic centers in the UK, that is Hammersmith Hospital, Imperial College in London, and also in Ireland at the National Maternity Hospital in Dublin. Her main interests are neonatal hypoxic ischemic brain injury and neuroprotection. That's a mouthful. She's going to have to unpack it for us who left school quite early. What is she talking about? But that is, the area of interest. She's published papers on this topic in peer-reviewed journals. She has presented lectures and workshops on therapeutic hypothermia and neuroprotection, both locally and internationally. She's recently completed her PhD in neonatology. That's just a few weeks ago. And she's currently the acting head of neonatology at Tygerberg Hospital. She's also the vice president of USANA, that is United South African Neonatal Association. So we have a guest who deserves for us to showcase, to show, to shine a spotlight so that, many more younger people can be able to know that there are people ahead of them who are actually doing great things, and maybe they'll also be inspired to become pediatricians and even neonatologists. So really, that's the purpose of today, to just celebrate Dr. Kali, because she has done very well. We were together at medical school in the 80s, and almost 30 years later, to actually be celebrating. Welcome to the Dr. Fundi channel.
Thank you very much for that.
Hi, good.
Can I call you?
Yeah, you can call me anything.
Hello, can you hear me?
Yes, I can hear you. All right. So, but before I talk to Gooks, one of the things that we do here, Dr. Kali, those people with clan names, we normally want to also make people know that they've got clan names. You were wearing a nice Xhosa, dress on the day that you went to get your PhD. So it is important that, we also acknowledge that side of you. Sure. Right. So you've already, in your bio, as I was introducing you, you told us that you come from Butterworth. But I want you to just tell us, a little bit about the family that you come from. And I know there's two of you, there's Temba, and then there's yourself, and Utata Wako, Upra Obri, was a medical doctor, no mama, but just tell me a little bit about your family, more especially, how is it growing up in a family where your father is a doctor and you end up being a doctor, but also the values that you learned from home as you were growing up.
Okay, thank you for that question. So as you've mentioned, so I'm the firstborn, yes. And then I have my brother Utemba, who is, so he's only 14 months younger. So when we were growing up, people thought we were actually twins.
I did think you were twins as well.
Yes. So we have always been very close as we were growing up. Yeah. But coming to values, so what I would say is what is one of the values that have always been important in our family was being humble.
Yes.
And being respectful of people, no matter where they come from and that you come across, because that shows that you respect yourself.
Yes.
Then the other very important value, I think, from both sides of the family has always been the importance of education.
Yes.
There was always, and not just academic education, yes. And especially from my father, intellectual curiosity has always been very important. So reading everything that you come across and reading widely and just acquiring knowledge about the world around you. Oh, there were always lots of books at home.
Yeah.
In fact, at some stage, there was a bit of an informal library where people would come and borrow books to read from. So there's always been, I think that's what he, growing up himself, had grown up doing. So I think that was the first thing. And then the other thing that my father, which will surprise you, it's always stressed is the importance of a good political grounding. So this will surprise you because I'm sure you've never heard him being in any political party. So this is not about.
I've never. Yes, no. Well, no. I've never. Honestly. So. Yeah, that's news. That's news.
But, he thought that this equips you and informs the way you understand the world around you and the way you present yourself into the world and other people, and even how you treat your patients.
Yeah. So that is one of the things that you've actually, taken. Even now.
Yes. I don't know, we're breaking up a little bit.
All right. I'm not sure what's happening here. Just hold on, Gugu.
Okay.
There's something that's happening here which I'm not sure. But anyway, all right, that's fine. So it's you mentioned humble or humility, respect, importance of education beyond just academic education, but just the curiosity to know what is happening, outside and around you, and also just understanding the politics as well. Besides those, what else would you say are the things that are still your compass even today, although you are an adult?
So, and then very important, importance of family. Yeah, I think that's always been one of the things that are important on both sides of the family. So
yes,
the family and the extended family. Yeah. Sorry,
yes, I mean that's one of the things I've always admired about your family. You guys are a very tight-knit family. You Temba, Utatu Obri, Nomamno Zenzele, but also the extended family, relatives on, Obotaba and other people around, So it's always been something I thought, wow, this family, when it comes to embracing family, nuclear and beyond, you're doing a great job. And when you were qualifying a few weeks ago with your PhD, they were all there to celebrate with you.
Yes, and you'll see it extends even beyond to the Mvambos, which was my mother's maternal grandmother's family. So we have a very wide extended family.
No, that's lovely. That's lovely. So, Doc, so you grew up in this family. Your dad was a doctor. At what point did you actually decide that I also want to follow my dad's career, to become a medical doctor?
I can't actually remember the point where I made that decision. I think I just I think when I started thinking about it, it sort of seemed like, so I guess, as you would probably know, having a daughter, we always idolize your father. So I think I always probably idolized my father and wanted to be like him. It just also happens that there are quite a few doctors in the family. So my maternal grandfather was a doctor, although I didn't meet him. And then there's many other doctors. My mother's sister was somewhat of a trailblazer herself, who became a pulmonologist. So I think there was always yes.
So growing up in that kind of family where you're not the first generation doctor, or you're not going to be the first generation doctor, your father had been there, and the other relatives have even gone beyond. It doesn't put any pressure on you as a child to say, yeah, if I do become a doctor, I'm going to have to take it, to a much higher level. Otherwise, I can't just be at the same level as them.
So my father did drop hints every so often. Hello, can you hear me?
Oh, okay.
Hi,
Gugu.
Yes. Can you hear me now?
I don't know. Hi, Gugu.
Hi, Fundi.
I can't hear you.
Oh dear. Shall I move?
Is not.
Can you hear me now?
Hi. Yeah, I can hear you. All right.
Do I need to move?
Eh?
Should I move? I'm not sure what's happening because the signal looks all right.
I'm just trying to see. Something is just not working well. I'm not sure what it is. Just hold on, Gugu.
Okay.
All right, but can you hear me though?
Yes, I can hear you well.
Oops.
Yes. Yo. Hi, Fundile. I can hear you.
Okay. I'm just going to remove something here and see how we do.
Okay.
Gugu, can you hear me now?
I can hear you.
Gugu?
Hello? I can hear you.
Because for some reason, I'm not picking up the sound from your side. Okay. Just give me a second, Gugu. Just give me a second. Let me sort out something. you hear me now, Cooks?
Yes, I can hear you.
But
I can hear
okay,
you.
there is something that is not.
I don't know.
Can you hear me now?
Yes, I can hear you.
Okay, I'm sorry about that. My camera seems to be playing some tricks on me, and apologies to those who've been watching. This is not how we normally do things, but let's hope that this is the last of the problems that we're experiencing. All right, let's go back, Gugu, to, I was asking you a question to say, growing up in a family of achievers, you know, a family where your dad was already a doctor, you've got relatives who are also medical doctors, others have gone beyond to become pulmonologists. Does that not, or did that not put pressure on you in terms of, if I do choose medicine as a career, I might have to go beyond, you know, what these other people have achieved?
Hi, Fundi. So can you hear me now?
Yeah, I can hear you now.
Okay. All right. So every now and then, my dad would drop these hints that he went further in terms of education than his father. So that I had a duty to go further than he did. So it wasn't very strong pressure, but every now and then there would be those hints that I needed to go further than being a generalist.
Yeah, so some form of gentle persuasion.
Yeah.
Lovely.
But having said that, it was, I think I did come to it on my own.
Yeah.
So when I was doing my internship, actually I did my internship at Cecilia Makiwane in East London.
Yeah.
So my last rotation in my internship year was pediatrics.
Yeah.
And I think after doing pediatrics, I just fell in love with it and didn't actually want to see adults again.
Wow.
So that was and I think part of it was the patients themselves, and also I think the people you work with influence how you feel about. So there was the consultants at Cecilia Makiwane just made it an environment that you wanted to stay in and possibly progress in.
So did you stay there as a medical officer, or you moved? At what point did you move to Cape Town?
So I stayed there. So after internship, I did obstetrics and gynecology just so that I can feel like a complete doctor. Yeah. And then I went back to pediatrics. And then I think I stayed for about 18 months. And then I went overseas just to get some overseas experience.
Yeah.
Where I stayed for just short of a year. And then came back and did a short GP locum. Yeah. And then I decided to go back. So then I went back and did my first year of registrar training in Cecilia Makiwane. Yeah. Because at that stage you could do that and then go to Cape Town. Yeah.
All right. So when you went to the UK, it was just for exposure, really. Yeah. And within a year, you were like, I think I'm good. I can go back home.
Yes. So that was the first overseas stint. Yeah.
Yes. And then the GP stint, how was it?
It was, I enjoyed it, but it was never going to be permanent. it was
not challenging.
Yeah. Yes. and if I'm honest, I don't think I I don't think I enjoy private work.
Yeah.
I enjoy more the interactions with the state patients.
Yes. Now, about pediatrics as a field, that is dealing with kids. Here we're talking up to 12 years old, right?
Yeah, sometimes a little bit longer. Yeah.
Yeah. So what was it that really attracted you in working with, kids? This is before now neonatology. I'm just talking pediatrics as a discipline. Was it the fact that they don't fake illness like us sometimes as older people, even if the doctor has cured me, but sometimes there could be other stressors. And so I don't, give you a true picture of whether I've recovered or not. So, and yet with kids, once you've sorted them out, they don't normally, fake things, and you will see them by playing and being nice and all of that. I'm just asking, Doc.
Yes. Yeah. Can you hear me, Fundi? There's a bit of
I can hear you. I can hear you, Gugu. Yeah. So yeah. So I was asking you about attraction.
Okay. Yes, I think that is a big part of it. That children, there is a certain honesty about children, and no clouding of issues. They're either ill or they're not ill.
Yeah.
And you can see when they're not feeling well and when they're all right.
Yeah. So
you still need to deal with the parents, but I think as patients, children are much, or at least for someone like me, more rewarding to deal with as patient.
Yeah. Okay. All right. And so you decided, all right, I'm definitely going for pediatrics. You started in Makiwane, and then you thought, all right, where do I apply to become a reg? So how did you get to be a reg at UCT?
So they had, at the time that I was training, they had a arrangement. They always did. It was sort of a satellite site of UCT where you could train in East London, so Makiwane or Frere.
Yeah.
So I had a relationship with the Cecilia Makiwane people because I had worked there before, so it was easier to get in there. And once you had got into the East London circuit, it was easy then to get into Red Cross.
Yeah. All right. Lovely. And so you guys, you're supposed to write many exams, first part and whatever. So did you write it whilst you were still in Makiwane, or did you write it when you got to Cape Town?
Yes, so I wrote part one in that year that I was at Makiwane, in the first year of training. So they had I think that was one of the attractions of going to Cecilia Makiwane. They had a very nice training system where they also supported you in preparing for the exam.
Beautiful. All right, so you wrote your first part, and then you got accepted at UCT. And so how was the move from Eastern Cape to the Western Cape? Any adjustment challenges there?
I can't say that there were major challenges. I mean, I did train at the time where there were still fewer people like me in the circuit. But it was not. My first rotation was neonatology, which was a little bit. So it's the neonatal part is at Hypoxic, so it's a little sort of separate small unit. So that may have also eased my integration into the system, and probably then influenced also my ultimate choice in doing neonatology.
Yeah. All right. So you did your peds, and when you were ready, and then you went and wrote your fellowship. Is it with the college?
Yes. Yeah.
Right. When did you get that?
So the FCP I got in 2001.
Yeah.
So towards the end of my work.
20 years ago. It's 2021 now.
Yes, I hadn't about that. Yeah, it is 20 years ago.
All right. So in the intervening 20 years, what has been happening, Cooks?
So after I finished, by that stage, I had decided neonates was my thing. So I was one of those registrars you probably know neonates is not for everybody, even amongst pediatricians.
Yeah.
So I was one of those people where if anyone wanted to swap out of doing neonates, I would volunteer to swap into neonates because I had decided that that was what I liked. So I think I did quite a lot of neonates during my general training.
Yeah.
So then, sorry.
No, continue talk.
Yeah. Okay.
Yeah.
So then when I finished, it also happened that there was a training post at Fortescue when I finished. So then I just continued and did the senior registrar or fellowship in neonatology after for the next 2 years.
Yeah.
And then I didn't write the exam because then I decided I wanted to get some overseas experience.
Yeah.
So then I left and went to work at the Hammersmith because of the resource constraints in the country. There are certain things that we can't do. For instance, we don't look after very small prems just because we have to limit and use the resources equitably.
Yeah.
So I wanted to see what it was like to work in a place where there were no constraints on resources and you could look after very small prems and do other things that we couldn't do.
Yeah.
So then I ended up at the Hammersmith in London.
And what was the, when you moved to that side, was there a big difference in terms of, the practice of neonatology? Like you've just said now, in some instances, there were resource constraints here in South Africa. So when you were exposed to the other side, was there a big gap between how they were doing things and how you were doing before you crossed over that side?
Actually, I wouldn't say so, except that the limits that we did things were not constrained. So yeah. I wouldn't say there was this very steep learning curve in terms of the general management. There were the one thing that was unique about the Hammersmith, it was a center for neonatal neurology. So there were lots of specialists or leaders in the world in neonatal neurology who worked there. So those were the things that were different, that even people from other UK centers would come there for, because they wanted to work with these specialists.
Yeah.
And then the other thing, sorry?
Yeah, no, continue talking.
So the other thing that was a bit of a culture shock to me was the number of doctors that were present. At some stage, you felt like you didn't know what to do with yourself because there were so many doctors in relation to the patients, which was a completely new experience to me.
Coming from a country where, the ratio of doctors to patients is usually not so great.
Yes.
In the country. So there was an oversupply, relatively speaking.
Yeah.
All right. So, Doc, now you said that place, you call it
Hammersmith.
Hammersmith. Right.
Yes.
Could that be the reason why you mentioned that hypoxic ischemic brain injury is one of your areas of interest? Could that have developed there? Obviously, you're going to tell us what that is,
Yes.
the damage to the brain as a result of, oxygen insufficiency, around delivery. So could that be the reason why you then took interest in that area?
Most definitely, yes. So my time at the Hammersmith coincided with when there were big trials going on. So for a long time, hypoxic ischemic encephalopathy, which is when the babies get damaged because of lack of oxygen. for a long time, there was no specific treatment for it. So we just had to support the babies and then they recover if they do or not. So in the last, say, 15 or maybe 20 years, there's been a lot of research into cooling or therapeutic hypothermia.
Yes, we're going to get
which
there.
is only, yeah, okay. So, but then my time in Hammersmith coincided with when these trials were going on.
Yes.
So, which is why my interest was piqued, because obviously it's actually a bigger problem here than there.
Exactly. All right. So you've just mentioned now that the issue of hypoxic ischemic encephalopathy or brain injury is much more common this side than that side. How common is it here?
It's so the statistics or the figures range a little bit. So in Cape Town, it's probably something like 4 babies per 1,000. Per 1,000,
yes.
But there are areas in the country where it goes up to 25 per 1,000. So even within the country, there is a bit of a range.
Yeah. Because when I read earlier today, they said 4 to 6 per 1,000, but this is globally, you know. But
yes,
in a country like ours,
yes,
with a lot of inequity, you know, with serious disparities, depending on which province you are in, it's likely to be a big issue. So what about that was really interesting to you? Okay, the first, that it was cutting edge, you know, kind of technology, cutting edge type of research. It was a big problem at home. What else was interesting to you about it?
Well, the fact that for the first time we have a treatment that can save babies from dying or getting neuro impaired with things like cerebral palsy.
Yeah.
And it was shown to definitely reduce the numbers of those kind of outcomes. And so when I arrived, I thought, well, this is something we have to introduce here at home.
Yeah.
Because it's a treatment that actually works.
Yes.
And it's not very difficult to implement.
Yeah. Yes. All right.
Babies do just need to be monitored carefully, but it's not a very technically difficult thing to do.
Yeah. But now, just going back to why do we have more of that here and in some of the provinces? Could that be a pointer to the quality of health services relating to either, you know, obstetric work or the quality of the health services themselves, you know, around labor? What do you think are the drivers in our country for that kind of challenge?
So yes, unfortunately, it can be a marker of the quality of care. And actually, even though cooling is very exciting because it works, the biggest impact we can make if you want to reduce the incidence would be on the management of the labor and delivery. That's what's been shown to actually make a real impact and save babies' lives. So that's actually what needs to improve while we do things like cooling as well.
Yeah. Because I picked up that, you know, when you're looking at the possible causes, it could be problems relating to the mother. It could be problems relating to the delivery. It could be problems relating to the baby. You know, that is inside. The things that may lead, you know, to the oxygen or blood supply not being, you know, enough to the brain around the delivery period.
Yes.
Right.
Yeah. So you've got it just right. But the things that we can probably make a difference in is around the management of the labor and delivery.
Exactly. But then if somebody gives birth in some outlying hospital, St. Elizabeth in Lusikisiki, you know, and they have to be taken to, you know, Nelson Mandela hospital in Umtata. I mean, those kind of things are not going to be changing anytime soon, you know, which may then result in the kids not getting the tertiary type of care that, you know, places like Tigerberg or Groteskir would be able to provide.
So are you asking what we can do in those areas?
No. I'm just saying, you know, like you said earlier, that the quality of health services, the efficiency of the system can determine whether, you know, the outcomes are good or bad. For example, you're going to talk to us now about the hypothermia, you know, hypothermia, you know, therapy,
Therapeutic
proven therapy for kids who are suspected or diagnosed, you know, with that brain injury from oxygen insufficiency.
So even, I mean, there are simple things that can be done even at places like St. Elizabeth. So there are programs like, for instance, the Helping Babies Breathe program, where people who attend deliveries can be taught basic resuscitation skills so that you don't need to wait or send the babies to somewhere specialized. The person actually at the delivery can assist. Most babies who don't breathe, that's usually the most that they will need some assistance with breathing. It's not very common that they need the extensive, sophisticated resuscitation. So at least everybody that attends a delivery has the basic skills just to assess a baby that may not be doing so well.
Yes. So, you know, as a country now, are we training our people then at that level to actually get those competencies so that there is something that they can do before thinking of sending to tertiary kind of institution?
Yes, so the Helping Babies Breathe program is a program that is being rolled out widely, even to the lower level centers.
Yes. All right. So can you just talk to us, Doc, then, because you said your area of special interest is this area of, you know, hypoxic ischemic brain injury, you know, and you talked about neuroprotection. Just talk. What is this neuroprotection you were talking about, Doc?
Okay. So shall I explain first what this hypoxic brain injury?
Yeah, you can do that. Yes.
Okay. So the hypoxic brain injury happens when something happens, usually around the time of birth, that cuts off the blood supply and therefore the delivery of oxygen to the brain. So it may be something where the placenta comes up or separates prematurely, or maybe a mother who had a Caesar and then has a ruptured uterus. So those are the very stark examples where you know exactly what happened. Most times it's not very clear exactly what happened. You just see a baby that struggles and doesn't really breathe nicely or start transitioning nicely after birth. But then you have a lack of blood supply and oxygen to the brain, which then manifests with a baby who is neurologically not normal after birth. So that's what we call the hypoxic ischemic encephalopathy.
And how soon is that identified, Doc? Is it something that has to wait for days, or within a few minutes, 5 minutes, 10 minutes, you can pick up that something is not right with this baby? This baby maybe, you know, is there anything that can point out to that possibility?
So usually, you should be alerted by certain things. So a baby that needs extensive resuscitation, so that doesn't transition nicely after birth, or a baby, if you then need to resuscitate the baby, it's also a good practice to do a blood gas on the umbilical cord, which will also tell you that this baby is in trouble. Those should be the first things that alert you that there's something that may be not right, and then you need to assess the baby very carefully. So babies can be different in terms of their resilience. So some babies may have go through that and be absolutely fine. And then some babies will actually go on to develop encephalopathy. So if you have a baby that you've had to help quite a lot, then you need to watch that baby carefully for the first few hours.
Yeah. Okay. All right. So, so the neuroprotection then, Doc, just what is that?
So that's like a global term for all the things that you need to do to make sure that you kind of secure or improve or give the baby the best chance of having a good neurological outcome. So therapeutic hypothermia is one of the things, that's the specific treatment, but there's lots of other things around it that you should do. Like, for instance, if you are ventilating the baby, making sure that you watch your blood gases, because if you over ventilate the baby, then you injure the brain again. Watching your blood sugar. So it's all the other things that you need to watch that to make sure that you protect the brain.
Okay, lovely, 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 lovely. All right, so you're saying this space has developed a lot in the last 10 to 15 years or so. You know, there are now better outcomes now that there are proven treatments like the one you're speaking about now, you know, the therapeutic
Hypothermia, yes.
Hypothermia, yes. All right, so you do workshops. Who do you give these workshops to? You know, you mentioned that you do a lot of work around, you know, creating awareness and educating people around this.
So it's to anyone who looks after newborns.
Yeah.
So it would be pediatricians and neonatologists or trainees in pediatrics. And we've done training also outside the country, some of the African countries who obviously have problems similar to ours, sometimes even bigger than ours. So they also want to introduce cooling in their setups.
Yes, yes. So this cooling, Doc, let's talk about it just in simple language. You know, you drop the temperature of a baby to a particular point for a certain period. Just talk to us in simple language, and why are you doing so?
Okay, so you drop the temperature. So it has to be done within a certain period after birth, because that's when it's been shown. If you wait too long, it may not work. So it has to be done within 6 after the baby has been born.
And then you
drop 6 hours after
6 hours.
birth.
Yes.
And then you drop the temperature by at least 3 degrees. So it's to 33. So the core temperature to 33.5 degrees. So that's the main. So most people do whole body cooling now.
Yeah.
When it started, there were 2 forms. You could do either head cooling or the whole body cooling.
Yeah.
But I think there's been a move to most people doing whole body cooling now.
Yes.
So you drop the temperature to those levels for 3 days.
Yeah.
And then rewarm the baby slowly back to normal temperature.
Yeah.
And then see how the baby does.
Yes. And the outcomes, you know, done properly, the outcomes have been found to be, you know, relatively good.
Yes.
Yeah. All right. So, Doc, then at some point you then decided, all right, I am not done with just being, you know, a neonatologist. I need to study further. Let's get to that point. Was it still part of making sure that you respond to that gentle persuasion by dad? Yeah.
So this is not going to sound very good, but I kind of stumbled into my PhD because so the first thing was the research. So I wanted to answer a certain question.
Yeah.
And then because I was doing the research anyway, I got to a point where I thought, well, why not do a PhD out of this?
Yeah.
So I didn't start off by, I'm going to do a PhD, what can I study? I wanted to look at this problem and then
find a solution to it.
Yes.
So that thing that you were taught earlier, that you must have intellectual curiosity, it came back.
Yeah.
Because now you identified a problem that needed a solution, and that solution needed research, so that the solution, whatever you bring as a solution, it's evidence-based, right?
Yes.
So what was that thing that you wanted to solve? What is this problem that you wanted to solve, Doc?
So the first thing I wanted to answer was so when I came back from the UK, I at that time, cooling or therapeutic hypothermia wasn't standard practice in South Africa. So I introduced cooling to Tygerberg when I came back in 2008.
Yeah.
Round about that time, a study came out from Uganda, which suggested that babies in Africa may not do well. They may actually, more of them may die when they are cooled.
Yeah.
So then there was a whole big hoo-ha throughout the world that maybe cooling wasn't appropriate in underdeveloped or developing countries or Africa. So my first thing was to show that actually cooling in the right circumstances, done within the protocols that were used in the studies, actually can be done and can have good outcomes. And we actually showed that we had very good outcomes. More than 80% of our babies had normal outcomes at 1 year.
Yeah.
So that was the first question.
Yeah.
And then the next study was actually looking at the outcomes of those babies that had received cooling in our setting, and then showing that the outcomes were good. And then the next question was, as good as cooling is, it's not a how should I put it? There were still some babies that were cooled that didn't have good outcomes, so it wasn't 100% successful treatment.
Yeah.
So there's lots of work throughout the world now looking at combining cooling with other neuroprotective therapies, because the issue with HIE, if I can abbreviate it, it has effects on many levels in the brain. So it kind of sets off a whole cascade of events that damage the brain in many different ways.
Yeah.
So people are looking at attacking different areas of these damaging processes to see if they can combine cooling. So that was one of my next study, was then combining cooling with another treatment.
Yeah.
To see if we can improve on the effect of cooling.
Yes. All right. So,
yeah.
Yes. And how did it go?
Unfortunately, not as well as we had hoped.
Yeah.
There were some, so the long-term outcomes were not much better than just with cooling on its own, although there's a suggestion that some early clinical markers may be better. So what we combined cooling with was morphine, because morphine has some immunological properties.
Yes.
And then we also did another study looking at levels of morphine in the cerebral spinal fluid of those babies that are cooled.
Yeah.
So it's just looking at different aspects now to see if we can improve on the effects of cooling.
Beautiful. All right. So I'm sure you guys haven't, you haven't stopped. You're still trying to get more answers.
Yes. Yeah. Definitely.
So your PhD then was on the issue of, cooling not being so suitable for underdeveloped world, and you have proven that that is hogwash. And then you zoomed in terms of the outcomes and analyzed that. So what other questions do you still have that you want to answer? Because obviously, once you get your PhD, you're not done. There's also a postdoc.
Yes, so there's still, yes, as you're right, there's lots of other questions that came out of this PhD that I'm hoping to answer. Like, for instance, so as I mentioned, the morphine has some immunological properties. So we also want to look at what it does to some of the inflammatory markers that you get in the brain and in the blood. So that's some of the work that I still need to do when I find time after this.
You must, but now they've made you, an acting head of the unit. So if you become the full-time head now, will you be able to continue to study?
Well, I hope so. I hope I can find time. It's very difficult because neonatology is always busy.
Yeah.
But I think we have quite a very supportive team that works in where we try and support each other. Obviously now, having got my PhD, I need to also support the others to get their PhDs. But we try and find ways to support each other and maybe cover each other to give it when someone needs time to do something and maybe just get a bit of headway in some research aspects. Because it's actually very difficult to, I didn't mention it, it took me 6 years to get this PhD. So doing a PhD while doing full-time clinical work is very difficult. Luckily, the university does also recognize that when you are a full-time clinician, so they give you a bit of time.
Yeah. I was going to ask you, because one of the questions I normally ask, my guests here is, as you are rising, what contribution are you making to lift others as you rise? So you've already partly answered that you are also mentoring and coaching other guys so that they too can get those PhDs. Now, I'm going to ask you a question, and maybe you may choose to answer or not answer. In the environment, and when I say now Western Cape, but I mean it's a national issue. The issue of gender and issue of race always from time to time, creates situations. Have you had any difficult situations, in all your training that has to do with the fact that you are a female, or that has to do with the fact that you have a lot of pigment on your skin?
So let me start by saying the pediatrics department is very and I've had, I think, as much support as I needed. But as you've said, the university is part of the country, so you will find some aspects that reflect the country that we live in. So sometimes there have been some issues where you can, for instance, you will people will only talk to you through someone else. You write them an email, they won't respond to you, and might only respond when someone else then also writes or intervenes and says, "This is so and so, they're trying to do this. Won't you please help them?"
And the issue of language. I know you are at Stellenbosch University, and for a long time, the language of instruction there generally has been Afrikaans, although there's been now some bilingualism. So issues of language, have they in any way hampered some of the work that you do?
So to a large extent, no. And I think, again, because I'm in the pediatrics department, because unfortunately, I talk to students just to find out how they are experiencing their life in the university. Sometimes it sounds like in some departments that may not be. So people will use language to exclude people. And occasionally, even with me, people will write emails where they know that I'm in the conversation and will just write in Afrikaans. Fortunately, those experiences are few and far between. But you do get, one day I walked into a lift and some older man said to whoever he was with. And it was clearly for my benefit. Someone said, they still speak English in my university, or something to that effect. And you could see it was clearly being said for my benefit. So you get a few people that obviously still want to keep things a certain way.
Yeah.
But fortunately, I really think in the pediatrics department, I would say it's not really an issue.
Yes. And the issue of gender, no issues there?
No. And actually there's an overwhelming preponderance of females in the department. We probably need a little bit more testosterone.
All right. So that's beautiful. That's beautiful. So so reflecting, Doc, now you've got your PhD. You are one of the top neonatologists in the country. You are actually one of the people who brought in, cutting edge, knowledge around HIE. So when you look back at your life, your career specifically to date, do you look back with a sense of satisfaction that, you know what, I'm on the right track? Or do you still feel that, you know what, yeah, I still have a long way to go?
No, I wouldn't change my career track. I think I'm definitely where I need to be. I do think there is still a long way to go in terms of solving the problems in neonatology, and for me personally in this field of hypoxic brain injury. There's still a lot of things that we need to answer.
Yes. So you are also a deputy president, the deputy president or vice president of the Association of Neonatologists. What does that entail?
So this is an organization which is maybe about 10 years old, and it was formed mostly to as a platform. It was a subsidiary of SAPA, which is the South African Pediatric Association, and it was formed mainly as a platform for collaboration between people that look after neonates, and to kind of promote good practice and evidence-based care of neonates. And the one of the main functions was we organized biennial neonatal conferences, which have been a little bit interrupted, obviously, with COVID. So we now have started, in fact, next month, we have our first webinar to try and bridge that gap, because we've had to postpone the physical conference.
Now, you've got people in the space that you are in, like Professor Velapi, Stanislaw Velapi, who was also, at our university before he came and worked here in Gauteng at Wits. How much interaction is there between you guys who are, neonatologists, but maybe you've recently qualified, and people like him who've been there for quite some time?
Yes, so Stay is obviously a trailblazer for all of us. So I think it's always been very good for people like me, and I think most people in neonatology actually, to have people like him. I mean, he sits on the international advisory councils on resuscitation, and so he's always been a very active advocate for neonates, and encouraging the rest of us to step up, basically, and get involved in the care of newborns. So we do interact quite a lot
with him. No, that's good. So as you are lifting up others that are coming after you, those who are ahead of you, like him, are also doing the same, essentially.
Yes, and I think it is very important to do that, especially for people like us. I mean, there are still very few of us, so we need to create spaces so that people coming after us can see that it is possible to come into the spaces and feel comfortable in the spaces.
Yeah. All right. So, so Doc is saying there's still a long way to go. There's a lot of questions to be answered, and so therefore that postdoc is definitely, coming. Right? Can I hold you to it?
No, I need to recover from the PhD first.
No, you already have got momentum, most, So you might as well just continue. But when you got that red rope, or that day, what did it mean to you, and what did it mean to your family?
Oh, it was, no, it's an incredible feeling that, all the slog and hard work has actually come to fruition. And I think my family was, I think they were very proud and happy for me. In fact, the one slight downside was, so I have an uncle who was my dad's older brother. He was kind of the head of the family. He was, so aside from my father, he was also one of the important people that were very strong intellectual influences in my life, and was always pushing and thought education was very good, and he was one who always thought I should specialize and reach the pinnacles of academia. So it was very sad that he died 6 years ago. So that was the slight downer, that he wasn't there to see me get that red rope, because he would have been very happy.
Wow. Okay. But remember your dad said, intellectual, curiosity. There you were now. Red rope. What did he say?
Oh gosh, I can't remember what did he say. But no, he was very happy.
He put out a challenge, and you responded to the challenge, and
No, I think he was very happy, and I think he thought I did Bonke very proud.
Yeah. And umama, kaloku must never forget about mama. Umama, ndifuna ukwazi umama, what did she say to you, mntanam?
Oh, she was very happy, because she always used to feel very sorry for me when they were visiting, and then I would ask them to wake me up, or I'd set the alarm to. Internet is unstable. Can you still hear me?
Yes, I can hear you. Yes.
Okay. Yeah, so she always felt very sorry for me, because whenever they were here or we were somewhere, I would always have to make plans to wake up early to do something, or I would have to leave them here and go to the office because I needed to work on my PhD. So I think she felt her little girl's hard work had paid off. So she was also very happy.
Yes, and the extended family, the broader family, Bomamu, Utlaba Mukwena, and the other close people.
Yes, yeah. So they were also very happy. My cousins, or Sis Pinky, Pumla, you probably know them from St. John's.
Yes.
They were all very, very happy for me.
Yeah. Now, we've got some
comments.
The
family is,
Yeah, we've got some comments here. There's a comment from Mandisan Nguza, says, Gugu, your interview with Dr. Fundi Nyati is very interesting. I'm very grateful to Sizenzi for inviting me to this virtual conversation. Halala mamtembu. And then there's another comment, but I think it's at the time where there were some connection challenges, from Jeff Lynn Segler, who said, we can hear and see you, Gugu.
My mom's comments, yes, thank you.
Yes, and then there's another one from Shane Jankipati. He was talking about the unstable network. And then Namsha Sihlali said, great work, Sis Gugukali. You are such a great inspiration to the younger generation of our country. Medical litigation due to the cases of HIE is debilitating. our public purse in South Africa, I'm certain your contributions will make a significant change to that. All right.
Thank you for those comments. I appreciate them. Yeah.
Yes, and just on this point that she's actually making, indeed, most of the provinces, especially the underdeveloped provinces, they have to put aside, billions and billions of rands because of the litigation relating to brain injury around, stuff that happened around delivery, which is the HIE you're talking about. So the more you solve these questions that you've already solved, I'm sure there will be positive spin-offs for the government, was they are taking money from service delivery to pay out some of these claims. Some of them are actually inflated, some of them are even fraudulent for that matter. Here in Gauteng, I am aware that there are even syndicates, that go and steal files and make sure that the government cannot defend the cases. So it's a big issue, but then people, with you and other colleagues of yours solving these problems, it will actually help the country to have its resources being used appropriately.
Yes, in fact, what I didn't mention is an ongoing study that we are doing, that a multi-center study that we're doing in various centers in South Africa, which incidentally Professor Velapi is also involved in, is actually looking at the genetics of babies that get HIE, to see whether there might be something in the babies themselves that because not all the babies respond the same way, having been exposed to the same insult. Yeah. So one of the important things, which hopefully might also help with this litigation issue, is if you can show that actually the baby did well because they had some genetic predisposition that made them susceptible to getting injured. So I think if we can answer those questions, it might help with the medical litigation as well.
Beautiful. So what next for you, Doc? I know we've talked about postdoc, we've talked about some of the questions that you still want to have answered. But for you, when you now, all of us at some point will be recalled to our creator at some point, what would you want to be your legacy? Where we say there was once this human being called Gugu who walked this earth, and this is the legacy that, obviously, I mean, this is premature now, but I'm just asking you that kind of question. Sometimes you work towards your legacy.
Okay, so obviously the one aspect is the one we've been talking about. If I can, by the time I retire, have made a significant impact into this whole question of managing babies with HIE, whether we find some other treatment that's going to make a significant dent in improving the outcomes, so that's one aspect. And then the other one is obviously if I can inspire other young girls or young females, or even males that look like me, to if just by my presence in Stellenbosch, I can make them see that this is doable. I can also come and work here and reach a certain level. So by the time I retire, there is a much more representative department, that would be another good legacy.
Beautiful. So I have not asked you yet about the gentleman who comes after you, who is 14 months younger than you. This Butemba.
Yes.
Now, what was Temba, or what did Temba say when you, made him aware? I've got this PhD I've been working on. what did he say to you? And let me start with that question.
Well, I think Temba has always probably has a shall I say, higher impression of me than I myself do. So I think for him, it was like, what else did you expect? I always thought this day would come. So I think he congratulated me, but I think he also thought it was always going to come. Yeah. He's always been one of my greatest cheerleaders and support.
Beautiful. And you are also cheering him on, because he's also doing great things on his chosen, profession.
Yeah.
All right. We are going to wrap up now, Doc. But what I want to know now, all right, and this is just, so you would like to at some point leave, when you retire, a transformed type of, department. When, I mean, the issue of language, I thought now it was settled that it's English and Afrikaans, but I see now things are being reversed. It seems like Afrikaans might just come back and become the sole language of instruction. So that tells me something about, the ability or the willingness to transform.
Yes, I have seen the discussions going on, and hopefully we will not really go back there. So I can only talk about my department.
Yeah.
I don't think I have much influence in the other department. But I think in our department there is a conscious effort to be inclusive. So what we need to do now is to actually have people that come after us applying and staying in the department, so that there's actually a pool of us to encourage the younger ones, even the undergraduate ones, who at times have told me that as soon as they finish, they're leaving, they cannot stay in this environment, to see that in welcoming environment that they stay in and progress and become specialists. Yeah. But I think we probably need to just start by having a core of specialists to create a culture that feels like, that makes people feel like they can also identify with it and thrive in it.
All right, lovely. So as we wrap up now, Doc, I know your parents, at least one or both of them, might be watching, because they invited other people to come and watch. What do you want to say to them?
Yes.
What do you want to say to them here and now? I know you've said a lot of things to them when they congratulated you, but I want you to talk to your mom and talk to your dad right here and right now.
Okay, so if you are watching, I want to say, Kudeni Nomjoli, I would never have reached this level if it wasn't for you pushing me, sending me to sometimes very expensive schools, just because you were interested in making sure I get the best education that you could provide, and also just always being supportive at whatever stage of my career. So
Thank you. To the rest of the extended family, it was, I understand the concept of it takes a village is really practical when it comes to you.
Yes, so to my aunties and cousins, a lot of my aunties have been sending very supportive, congratulatory messages. So ndiyabulela kuni nonke. Auntie wami Marina, Professor Xabamkwena, thank you for being the trailblazer that you've always been and showing us what can be done. She's actually always been known in the family, even from a young age before she became a doctor. She's always been a go-getter. Apparently, she started driving a car at 14 when nobody else was driving in the town. So she's always been one of those people.
And they still drive from East London to Johannesburg, even now at her age of 84, I think.
Exactly. Yeah, so to the rest of my family as well, I really thank you very much. My cousins, I'm not going to name them in case I forget someone, but thank you very much to all of you for cheering me on.
All right. And to young ladies out there who are still to choose a profession, or those who are already in the medical profession who were still contemplating Uguti, which discipline of medicine would they like, to take forward? What message do you have for them?
So the ones who are already in medicine.
Well, I'm just saying anybody who has listened to you, they may not have yet joined medical, profession, or training. So what do you want to say to them? I mean, you've already said there's a shortage of people like you. So it means there's a need to swell the ranks, of pediatricians and even neonatologists out there.
So I think, yes, so it's a very rewarding, enjoyable, special pediatrics and neonatology in particular. But it is very hard work. So firstly, you have to have a love for it. You can't just do it because you want to specialize. You have to identify with it and have a love for children and maybe newborns, and then recognize that it is very hard. It's hard work getting the qualification, and it's hard work when you're actually working in it. It's one of the specialties where you really have to work hard. So you need to be clear in your mind that you are dedicated to children and this is what you want to do.
No, I think.
But having done, if that's where you are at, it's a very rewarding career.
Thank you very much, Makudeni, Mam Velase, Mam Pafane, Mam Tembu. I think you've made the clan and just everybody very proud. When I saw your picture a few weeks ago after you had just graduated, I knew that I needed to have a chat with you. I also knew that you are somebody who's reserved, who doesn't want to make noise. But some of us like to make sure that we make noise when somebody has achieved. And so thank you very much for agreeing to have this conversation with me, because it's not just about us, but it's also about inspiring others, and actually, because sometimes people lack role models, they've never seen somebody who looks like them, who is a neonatologist. So now at least they can say, we saw Dr. Gugu, she is a neonatologist, she's got a PhD, and she's planning to still continue and study further. And she wants to make it in an environment that is, still changing. So with you agreeing to have this interview, so many people, have been inspired by everything that you've shared. And so for that, I really want to thank you from the bottom of my heart.
Thank you very much, Fundi. And I'm really honored. And as I said earlier, I'm also very admiring of the work that you're doing. So congratulations to you too. Thank you very much.
All right. Thank you very much, Gugu. Dr. Gugu Kali was our guest. Thank you. We appreciate her, and we'll continue to to monitor what she's doing, so that if she adds more things, we will call her back for her to update us again. So thank you, man, Gugu, and thank you to everybody who logged in via the various social media platforms. This is what we do on Sundays. We try and shine a spotlight on somebody who is doing great things, and as you've heard, Gugu is doing great things, and we still expect more from her. With those words, I just want to say thank you very much to everybody. Till next time.
Thank you, Fundi. Bye.
Thanks, folks.